Now students, in this video we are going to complete the PNS, that is the peripheral nervous system. In peripheral nervous system we are going to take two parts, that is the first is local anesthetics and second is the smooth muscle relaxants. Okay, so now let's start with the local anesthetics without wasting any more time. So local anesthetics are basically the drugs which block the conduction of nerve impulses along the axon. Okay, so these are local anesthetics. Now it is very important to understand their blockade pattern. So they block small diameter nerve fibers more than large diameter nerve fibers. And small diameter nerve fibers are also called as B and C type, while large diameter nerve fibers are called as A types. That means we can say that small diameter nerve fibers are more sensitive. Okay. Then second is myelinated nerve fibers are affected earlier than non-myelinated. Okay. Then autonomic nerve fibers are more affected than the sensory, and then more than motor. And in sensory, it is seen that pain is affected first, followed by temperature, followed by touch, followed by deep pressure, and followed by proprioception. Okay. Now these local anesthetics, they're classified into two types. What is their classification? Now they're classified as amides and esters. Amides are lignocaine, prilocaine, then bupivacaine, then dibucaine, then mepivacaine, okay, and etidocaine and ropivacaine. So these are called as amides. And in esters we have cocaine and procaine and chlorprocaine, tetracaine and benzocaine. So these are the drugs which are esters. Now understand that chlorprocaine is the shortest acting, okay, and dibucaine is the longest acting. Okay, कुछ ये तो basic सी चीजें हैं that you should remember with the amides and esters. Then another important difference that we would like to tell here, that amides, why amides are preferred? Amides are preferred because they produce longer lasting anesthesia and which is also more intense anesthesia. They bind to alpha-1 acid glycoprotein, okay. Then they are not hydrolyzed by plasma esterases, and very important, they rarely cause hypersensitivity. So these are the important things, classification related to amides and esters and why amides are preferred. And this is the important blockades, how they are blocked, like small diameters more than large, myelinated more than unmyelinated, and autonomic more than sensory, more than motor. And in sensory, this is the way they are classified. Now let's see the next part, that is let's see the mechanism of action. Now what is the mechanism of action? It is very simple. Now just imagine that this is the membrane and this is the sodium ion channel, right? This is the sodium ion channel. Okay, now this sodium ion channel has got three phases: resting, activated and inactivated. Okay, and the receptor for local anesthetic is present here. This is the receptor, binding site for the local anesthetic. Now what happens is that local anesthetic is a weak base. Okay, so what it does is that this is the outer area and this is the inner area, inside the cell. Now local anesthetic, which is in an ionized form, gets first unionized. This is the ionized form, this is unionized. In the unionized form, it crosses the membrane and it comes inside, and then it converts into an ionized form here. Then from here it goes and attaches to this receptor from the inside part. Okay, and so what it does is it basically blocks the channel in the inactivated state. Local anesthetic blocks channel in inactivated state, right? And it binds to the receptor from inside the cell. Okay, so it binds from the inner surface and then it blocks the channel in the inactivated state. So this is something that you must remember always. Another important thing, that soda bicarb is found to increase the process. It's found to speed up the process. Why it is going to speed up? Because it is an alkali. It will produce an alkaline medium. So in alkaline medium, this base will remain unionized and more will be available to cross the membrane. So this is how the local anesthetics, they act on the sodium membrane, right? Now next we come to the another classification. It is important to remember the classifications because that helps you in remembering the drugs also. Now they are classified into two types. What are they? surface anesthetics and injectable anesthetics. Okay, now what are the surface मतलब topical. Okay, and injectable मतलब ये हो गया in subcutaneous infiltration or it is intravenous nerve block or field block type of anesthetics. Now in surface anesthetics we have two types, soluble and insoluble. Now soluble में we have cocaine, lidocaine or lignocaine, then we have tetracaine and proparacaine, and insoluble में we have benzocaine and oxythazine. Okay, so these are the surface anesthetics. Then in injectable anesthetics we have three classifications of low potency, then intermediate potency, okay, and high potency. Now in low potency we have procaine and chlorprocaine. In intermediate potency we have lignocaine and prilocaine, and in high potency we have bupivacaine, ropivacaine and divacaine. Right, so this is the classification of these drugs. Okay, now moving on to the specific characteristics. Now let's discuss some general things related to the local anesthetics. The first thing is that adrenaline prolongs the duration of action. Okay, and there's another vasoconstrictor, that is felipressin. It is also used to avoid the CVS complications. Now remember that adrenaline not added in what all conditions? Now not added in conditions and artery organ like earlobe, then fingers, then penis. So these end artery organs are not to be used. Second, when halothane is given, because halothane will sensitize the myocardium to the arrhythmic actions of adrenaline in a patient of myocardial infarction, in a patient of hyperthyroidism, and in a patient of severe hypertension. And it is not to be given in IVRA, that is intravenous regional anesthesia, which is also called as Bayer's block. Okay, now other things related to drugs. So the LA causing vasoconstriction. Now all the LAs, they cause vasodilatation except for cocaine. So cocaine is the only local anesthetic which causes constriction. Okay, then most commonly used LA is lignocaine. Shortest acting मैंने आपको पहले बताया था is chlorprocaine, longest acting is divacaine. Then LA causing methemoglobinemia, what is that? That is prilocaine. So this is the LA that causes methemoglobinemia. Then LA which is maximum cardiotoxicity कराता है, that is bupivacaine. Then another important thing about cocaine, never give IV or with adrenaline. This is something very important for cocaine. Cocaine is the only ester which is not metabolized by pseudocholinesterase. Okay, so this is another point related to cocaine. First of all, cocaine is the only drug that causes vasoconstriction, and cocaine is the only drug which has not to be given IV or with adrenaline, and only ester which is not metabolized by pseudocholinesterase. Then next, procaine in local anesthetic. Procaine is the local anesthetic of choice in malignant hyperthermia. So malignant hyperthermia is something caused by halothane, and in that condition you can use procaine. Okay. Another important, chlorprocaine is contraindicated in spinal anesthesia. Never give chlorprocaine. Why it is contraindicated? Because it causes paraplegia. Why it causes paraplegia? Because it has got a neurotoxic substance which is sodium metabisulfate. So this is the problem with chlorprocaine. All LAs, they cause CNS toxicity. If they are systemically, if they enter the system, then they cause CNS toxicity, which presents as seizures most of the time. Okay. Then divacaine is the longest acting, right, most potent, right, and most toxic also. This is the specific feature of divacaine. Lignocaine is the most commonly used, right. Then it is the drug of choice in ventricular tachycardia. It can precipitate malignant hyperthermia. Okay, so this is something which we have to remember for lignocaine. Now, dose of lignocaine. It is 7 milligram per kg with adrenaline, and it is 4.5 milligram per kg without adrenaline, and it is 4 milligram per kg in buyer's block. ओके, ठीक है, आगे चलते हैं. ब्यूपिवेकेन, एज आई टोल्ड यू अर्लियर, दिस इज कार्डियोटॉक्सिक, मोस्ट कार्डियोटॉक्सिक ड्रग होती है. इट इज़ द बेस्ट ड्रग फॉर रीजनल ब्लॉक. शुड नॉट बी यूज्ड फॉर बायस ब्लॉक. इट इज़ नॉट रिकमेंडेड फॉर बायस ब्लॉक. ठीक है, नाउ आगे चलते हैं. Let's see the various types of anesthesias. Okay, what are the various types of anesthesias? तो सबसे पहले हम पढ़ते हैं surface anesthesia. Surface anesthesia basically it is topical on mucous membranes, but it is ineffective on intact skin. Okay, this anesthesia is ineffective on the intact skin. It is applicable only on mucous membranes. A mixture of 2.5% Prilocaine plus 2.5% lidocaine in 1:1 ratio is called as eutectic mixture, and this is can be used as ointment on intact skin. Okay, so this is eutectic mixture which can be used on the intact skin. Now a drug is there, that is oxythazine. Oxythazine was used as a symptomatic relief in gastritis, so that was also a kind of topical use, but now it is not used so much. Okay, next we come to the second type of anesthesia, which is called as infiltration. Infiltration anesthesia means there is a subcutaneous injection. Okay, now this subcutaneous injection basically to block the area and usually added with adrenaline. Now इसमें आते हैं nerve block, right, which is usually given around the nerve trunks. Right, now there is something called as brachial plexus block. So remember that it causes sometimes a complication which is known as pneumothorax. Brachial plexus block can cause pneumothorax. Right, then we have something called as IVRA, that is Byers block, in which a tourniquet is tied at the limb and then the anesthetic is given. So the pressure in tourniquet, this is very specific, remember, should be 50 millimeter mercury more than the systolic blood pressure of that person. Okay, the drug of choice in IVRA is prilocaine, or lignocaine also can be used, and never mix it with adrenaline, and contraindicated in sickle cell anemia. So ये हमारे detail है related to infiltration anesthesia. Please remember them very carefully, that in Byers block never use adrenaline, don't do it in sickle cell anemia. The next category that we discuss is spinal root anesthesia. Now spinal anesthesia is something which is given in subarachnoid space. Okay, this is subarachnoid space between pia and arachnoid matter, in the intrathecal space, in, this is very specific, L2 L3 in adults and L4 L5 in children. Okay, please remember this. There is a differential blockade. What is that blockade, differential blockade? That autonomic sensations are gone from 2 segments higher, and motor sensations are 2 segments lower than sensory. Okay, so remember these important things. Coming to the toxicities. Now toxicities में सबसे पहली toxicity होती है hypotension, right? Now hypotension, it occurs because of their tendency to vasodilate. Second is headache. Headache, why? Because it is called as post-dural puncture headache. Now post-dural puncture headache है, इसको आप कैसे ठीक कर सकते हो? सबसे पहले तो this is an occipital headache, right? It is usually seen after 12 to 24 hours. ठीक है? It is made worse on sitting supine. ठीक है, and third thing, it is relieved by abdominal compression. Okay, and another thing is small bore needle, that is 25G, sorry. 25G needle use should be there to reduce the leakage of this thing CSF from the dura. Then other side effects that can occur are urinary retention, then paralysis of cranial nerves, then it can even lead to Kodai-Koena syndrome. So these are some toxicities which are seen with the local anesthetics. The most important thing that they can ask you is about the headache part, right? Then a very important term or a very important thing on which a lot of MCQs are also asked: local anesthetic systemic toxicity. Okay, local anesthetic systemic toxicity. What does it mean? It means that patients usually presents with symptoms like arrhythmias, cardiovascular collapse, seizures. Okay, so what is the treatment? CPR, then 20% intralipid. It is the drug of choice. Remember this, it is also asked in a lot of MCQs that systemic toxicity by local anesthetics, the drug of choice, you will give 20% intralipid. इसके अलावा you can give benzodiazepines for seizures, you can give soda bicarb for acidosis, and avoid class 1B drugs for arrhythmias. Okay, so these are the important features related to the local anesthetic systemic toxicity. Now another route is remaining, that is epidural. Epidural route is basically epidural anesthesia, where it is given in the epidural space by Tuohy's needle. Okay, now this epidural space, it runs from foramen magnum at the top to sacral hiatus, right? So it affects the anterior and posterior nerve roots, veins, and lymphatics. This is something important for the epidural space that you should remember. The last thing in local anesthetics, contraindications to spinal. What are the contraindications to spinal anesthetic? Raised ICT अगर है तो then don't give. Mentally ill patient है तो then not to be given. Mentally ill, uncooperative or psychiatric patient, local anesthetic should not be used. Then in patients with shock, hypotension or hypovolemia, not to be given. If the patient has any bleeding disorder, then it is not to be given. Then infants and children में spinal should not be given. We should just go for general anesthesia. Then if there is some infection at local site, never give local anesthetic. If there is some vertebral abnormalities, then not to be given, otherwise you will just damage the vertebra. So infection or sepsis. So these are the contraindications to spinal anesthesia. So with this we finish the local anesthetics, and next we take up skeletal muscle relaxants. Now in peripheral nervous system, the next thing that we are going to complete is the skeletal muscle relaxant. Now skeletal muscle relaxants are basically drugs which relax the muscular system. Okay, muscular system को relax करते हैं for operation, for facilitating a proper operation of that patient. They are also used to facilitate the endotracheal intubation of the patient. So by relaxing the laryngeal muscles. Okay, so this is the main use of the SMR. Now let's see the classification. So सबसे पहले हम इसका classification समझते हैं. Now in the classification we have two type of drugs. One are centrally acting drugs, that is these drugs they act on the CNS, and the second category that we have is peripherally acting drugs. Right, now centrally acting drugs may we have benzodiazepines, in which we have diazepam. Then we have central alpha 2 agonist, in which the drugs that are used is tizanidine. Okay, then we have GABA mimetics. So in GABA mimetics we have thiocolchicide. Okay, and the fourth category that we have, they are mefenecins. So in this we have chlorzoxazone, then methocarbinol, then carisoprodol, and chlormazanol. Okay, so these are the centrally acting drugs. Benzodiazepine agonist, that is diazepam. Central alpha 2 agonist, that is tizanidine. Then GABA mimetics, in which we have thiocolchicide, one more name is there, baclofen. And mefenacin derivatives, in which we have carisoprodol, chlorzoxazone. These are very commonly used drugs. Like you can, if you see the labels of important drugs, you will find them in that label. Now we come to the peripherally acting drugs. Now peripherally acting drugs are divided into two types. Okay, so one is directly acting. Okay, and then second is those drugs which are acting on neuromuscular junction. I'll write it as neuromuscular junction. So neuromuscular blockers. Now neuromuscular blocker drugs are again of two categories. The first category consists of competitive blockers, and the second category consists of depolarizing agents. Now depolarizing agents may we have succinylcholine and decamethonium. Okay, now in competitive blockers we have three types. What are they? Long acting, intermediate acting, and short acting. In short acting we have one drug, that is mivacurium. In intermediate acting we have vecuronium, atracurium, cisatracurium, and rocuronium. Okay. Long acting we have the first drug, that is D-tuberculin. Then we have pancuronium. Then we have doxacurium, and we have pipecuronium. Okay, so these are the three drugs that we have in that category. So I'll just revise the drugs which are acting once again. So we'll just see the classification once again, that we have centrally acting, we have peripherally acting. Centrally acting we have benzodiazepines, GABA mimetics, then alpha-2 agonist and mefenacin derivatives. In peripherally acting we have directly acting and those acting on the neuromuscular junction. Now directly acting there is a drug which is dantrolene, and this drug you all have heard a lot about it. So directly acting we have dantrolene, and in competitive blockers then we have long acting, intermediate acting, and short acting. Short acting is like this: mivacurium, intermediate mein vecuronium, atracurium, rocuronium. Long acting mein we have DTC, pancuronium, doxacurium, and pipecuronium. Okay, now let's finish them one by one. So सबसे पहले we will take centrally acting. So centrally acting drugs, let's take them one by one. सबसे पहले हम अगर बात करें mefenacin derivatives, so इसमें these drugs they inhibit the polysynaptic reflexes. So they are used in local spasms, muscle relaxants, right? Then the other category that we have is benzodiazepines agonist. Now these drugs they inhibit both polysynaptic and monosynaptic reflexes, right? So these drugs they inhibit both polysynaptic and monosynaptic reflexes. Now benzodiazepines are also used in muscle spasms. The next category that we have is GABA B agonist. GABA B mimetics होते हैं. Now this is a G protein coupled receptor, and to make you remember, GABA A is an ion channel pentameric rosette structure होता है, but GABA B is a G protein coupled receptor. तो इसमें हमारे पास जो GABA mimetics होती हैं दो drugs हैं, baclofen and thiocolchicide. So baclofen basically it increases potassium and inhibits both monosynaptic and polysynaptic reflexes, right? And thiocolchicide, it is, apart from being a muscle relaxant, it is also anti-inflammatory. It also acts on GABA A, and it also is a glycine receptor antagonist. Okay, so uses इनके कहाँ पे है? They are used in spasticity of multiple sclerosis, amyotrophic lateral sclerosis, and importantly, baclofen is not used in cerebral palsy. Remember this. Then thiocolchicide का एक है, it is contraindicated in epilepsy because it is proconvulsant. It can precipitate seizures, so it is contraindicated in epilepsy. Then another drug that we have is alpha-2 agonist, which is tizanidine. Now this tizanidine does not have any effect on blood pressure, unlike clonidine. Okay? It also reduces mono and reduces polysynaptic reflexes. This is also used in multiple sclerosis, amyotrophic lateral sclerosis, and spinal injuries, spasticities. Okay, so these are the various centrally acting drugs: mefenacin, benzodiazepines, GABA B, baclofen, colchicide, tizanidine. Now let us see the directly acting drugs. अब डायरेक्टली एक्टिंग ड्रग्स क्या करती हैं? ये बेसिकली इसमें एक आती है ड्रग dantrolene, and quinine. ठीक है, they act directly on skeletal muscles. Okay, these drugs act directly on the skeletal muscles. How do they act? We know. What does dantrolene do? Dantrolene inhibits which receptor? Ryanodine receptors, and it reduces the release of calcium ion. This is the mechanism of action of dantrolene. So these drugs are used to relieve spasticity and multiple sclerosis, cerebral palsy, and spinal cord injuries. Plus, write it in different. Dantrolene is the drug of choice for malignant hyperthermia, which is caused by halothane and succinylcholine, and also neuroleptic malignant syndrome. Okay, adverse effect होते हैं इसके, can result in hepatocellular injury, so hepatitis, and also causes muscle weakness because it is inhibiting the secretion of calcium ion. Then quinine भी हमने लिखा था ना यहाँ पे. So quinine, it actually decreases the excitability of the motor end plate. Okay, so this is the mechanism of action of quinine, and so it is used in nocturnal leg cramps. Okay, so please remember quinine, because it reduces the excitability of the motor end plates, it is used in the nocturnal leg cramps, right? Now coming to the next part, now let's see the drugs acting on neuromuscular junction. What are the drugs acting on neuromuscular junction? Now in this, as we have seen, there are two categories: depolarizing and competitive, right? So now let's see the depolarizing agents first. Now in depolarizing agents, the drug that we have is succinylcholine. Okay, now this succinylcholine is actually an acetylcholine analog. Okay, and due to this ability, it causes depolarization of NM receptor, that is nicotinic receptor present on neuromuscular junction, and due to depolarization, it causes fasciculations. Okay, so fasciculations are present with succinylcholine. After on prolonged use, जब लंबे समय तक इसे देते हैं तो जाके फिर ये basically it makes the end plate refractory to the impulse. ठीक है. Now because it is causing fasciculations, so the side effect of post-operative muscle soreness and pain, post-operative pain is there, post-operative muscle soreness is there with succinylcholine. ये इसमें रहता है इसके साथ. ठीक है. And then on prolonged use, then it is causing this block. So this type of thing, now here, because it is causing depolarization, what is the type of paralysis it is causing? It is causing a flaccid paralysis, and flaccid paralysis which is reversible by neostigmine. Okay, which is called as phase 1 block. Sorry, which is not reversible by neostigmine. On prolonged use, when it makes the end plate refractory, then it is called as phase 2 block, where then it can be reversed by neostigmine. Okay, so this is basically the mechanism of action of succinylcholine. Please understand this mechanism. It is an acetylcholine analog, and it causes depolarization of NM receptor, causes fasciculations, and on prolonged use, the end plate becomes refractory finally. Then succinylcholine के बारे में दो चार चीजें, that it is the shortest and fastest acting SMR. It is the preferred SMR for endotracheal intubation. Okay, then it is metabolized by pseudocholinesterase, and a genetic defect, genetic polymorphism, can result in patients with this genetic defect to have a prolonged apnea. This prolonged apnea by succinylcholine is caused in patients having a genetic deficiency of pseudocholinesterase, and this is assessed by Dibucane number. Okay, then succinylcholine stimulates autonomic ganglia, while in comparison the competitive blockers inhibit the ganglia. Okay, another problem with succinylcholine के ऊपर बहुत questions आते हैं, so please, it looks small but it is something very important. Now the second point is that succinylcholine causes hyperkalemia in nerve and muscle disorders. Okay, so it is contraindicated in nerve and muscle diseases, right? So this is also important. Then succinylcholine increases all pressures. कौन से pressures? Intracranial pressure increase करता है, so it is contraindicated in head injury. Okay, it raises intraocular pressure, so it is contraindicated in glaucoma. Then it raises blood pressure. It also raises gastric pressure, so that can result in vomiting. Okay, and succinylcholine can precipitate malignant hyperthermia with halothane. Okay, so this is another important thing with succinylcholine. So these are some side effects of succinylcholine that you need to keep in mind. It causes hyperkalemia, then it increases all the pressures, and then it can precipitate malignant hyperthermia. So with these particular conditions or complications have to be kept in mind when you are using succinylcholine, right? Next, we move on to the competitive blockers. Okay, now these competitive blockers, they're very simple. They block the NM receptor. So there is no fasciculations, there is no post-operative pain or soreness, and they are reversed by neostigmine. Okay, it can be reversed by neostigmine. So this is the competitive blockers. Now let us see their classification. They are divided into two types. The first is steroidal and the second is benzyl isoquinoline derivatives. Now in benzyl isoquinoline derivatives we have D-tuberculadin and we have metacurine, we have doxacurine, we have atracurium, cis-atracurium and mivacurium. Okay, in steroidal we have pancuronium, we have vecuronium, we have pipecuronium, then we have rocuronium and we have rapicuronium. Okay, now little things I'll tell. Steroidals, they have a very less effect on histamine and they have no effect on ganglia. Okay, and these drugs, they release histamine, so you can understand that they'll be causing some complications, and they also block the ganglia. Okay, now some characteristics about these drugs. Pancuronium causes tachycardia because of its vagolytic activity. It blocks M2 receptor. Rocuronium is fastest acting and it is considered as an alternative to succinylcholine for endotracheal intubation. Okay, then rapacuronium is withdrawn because it causes severe bronchoconstriction. Then vecuronium is used in cardiac patients but contraindicated in liver and biliary obstruction patients. Then there's a drug gantacurium. This is under investigation, shortest hai, and so it is considered as an alternative to succinylcholine in endotracheal intubation, right? So these are some characteristics of the steroidal drugs. If we come to non-steroidal, the benzoisoquinoline derivatives, here you'll see that they cause bronchospasms. So these drugs also cause bronchospasm. Then हम एक characteristic लेते हैं, तो जो doxacurium है, doxacurium यहाँ पे longest है and most potent भी है. Mivacurium जो है, ये shortest acting है and इसका जो degradation है, this happens by esterases. Then atracurium, the very specific fact about atracurium is that it is eliminated by Hoffman's elimination, right? And what is Hoffman's elimination? Hoffman's elimination is basically a spontaneous non-enzymatic rearrangement. Okay, so a spontaneous non-enzymatic rearrangement is called as Hoffman's elimination of atracurium. Atracurium is the drug of choice in hepatic and renal insufficiency. Okay, and another important thing about atracurium is that atracurium is metabolized to laudanosine, and this laudanosine is responsible for seizures. That is why there's another drug that is called as cis-atracurium, and this cis-atracurium is safe, right? So this is the detail regarding the atracurium. Now let's move on to इसी में एक और दवाई है गैलेमाइन. गैलेमाइन it is basically now not used, it is least potent, नेफ्रोटॉक्सिक होती है, teratogenic होती है, and causes tachycardia. So galamine is another drug, but it is not used nowadays. Okay. Now let's talk about the reversal. So we know that reversal is usually done by neostigmine, right? But now there's a new compound. What is that new compound? New drug. It is Sugamadex, right? So this is Sugamadex. Now this Sugamadex has no cholinergic side effect. It is used only for steroidal SMRs, not used in benzyl group and succinylcholine. Okay, Sugamadex is basically a gamma cyclodextrin. Okay, so this is Sugamadex. It has no cholinergic side effect. It is fast acting also. Okay, so it is basically a fast, also called as fast selective relaxant binding drug. Okay, so this is all about the neuromuscular, the drugs which are basically blocking the neuromuscular junction. And with this we finish the PNS. Next we are going to take kidney.